Welcome to the Mental Illness and Schizophrenia lecture. Today, we'll be discussing multiple neuropsychological conditions that affect mood and influence everyday daily activities we take for granted. So following the first part of this lecture, which focuses on mental illness, you should be able to discuss the history of mental illness and our understanding, explain and discuss the nature of anxiety disorders, including panic disorders, agoraphobia, and obsessive compulsive disorder, also known as OCD. Explain and discuss the nature of affective disorders, including major depression and bipolar disorder. Understand and explain the biological basis of both anxiety and affective disorders, including but not limited to the involvement of the HPA axis, the diathesis stress theory, and the monoamine hypothesis. And finally, to be able to discuss the treatment options for anxiety and affective disorders. So to start off with, we'll introduce to you some of the distinct branches of medicine that concern brain functioning and psychological well-being. The first branch that you're all probably familiar with or have heard at some point is neurology. This branch of medicine concerns the diagnosis and treatment of nervous system disorders. For example, Alzheimer's disease, Parkinson's disease, epilepsy, and so on. Although some of the world's most challenging diseases and disorders are neurological, they each help to shed light and clarify the role of physiological processes in both normal and abnormal brain functioning. The second branch of medicine we consider important is psychiatry, as well as psychology, which we believe should also be included here. These are branches of medicine and health concerned with the diagnosis and treatment of disorders that affect the mind or psyche. Some of the most common neuropsychiatric disorders that affect individuals in society include anxiety disorders, depression, bipolar, and schizophrenia, which we'll be learning about today. So similar to previous lectures, we'll also go through the history of mental illness briefly. And in fact, similar to epilepsy, early neuroscientists believed that mental illness was caused by supernatural phenomena and demonic possession. After contemplating why a feeling of pain caused mental distress, a philosopher named Descartes proposed that mental illness involved disorders of the body and mind. However, it is now widely accepted that most mood, thought, and behavioral disorders have some sort of biological underpinning. This has led to the current definition of mental illness as being a diagnosable disorder of thought, mood, or behavior that causes distress or impaired functioning to daily life. And if you have ever experienced feelings of sadness or anxiety, it is likely that you too have noticed such changes in your behavior. When we think about what causes disorders affecting the mind or psyche, there are two key mutually interacting factors: heredity and genetic susceptibility, so that's our genes, and also environmental factors. It is the interactions between these factors, that can determine whether, one, an individual develops a mental disorder, or two, whether certain individuals are at a higher risk of developing a mental disorder, and we will discuss this more later. So two notable psychosocial approaches to mental illness have been proposed. Freud's theory, also called psychoanalysis, suggested that in mental illness, unconscious and conscious elements of the psyche come into conflict. By contrast, Skinner, a prominent American psychologist, proposed Skinner's theory of behaviorism, also known as operant conditioning, and this argues that many behaviors are learned responses to the environment and can lead to maladaptive behavior. There are also biological approaches to mental illness which give clear links to what may be causing the ailment. For example, general paresis of the insane, also known as dementia paralytica, is a severe neuropsychiatric disorder, classified as an organic mental disorder. The term organic mental disorder refers to illnesses caused by medical and physical disease of the brain, rather than psychiatric illness. General paresis of the brain is caused by the chronic frontotemporal meningoencephalitis that leads to cerebral atrophy, and this causes a loss of cortical functions in late-stage syphilis infections. Typically, it occurs approximately 20 to 30 years after the initial exposure to T. pallidum, the bacteria that causes syphilis, and its symptoms, which can range from mania to cognitive deterioration. Thankfully, in 1910, Paul Ehrlich discovered arsphenamine, which cured syphilis. Other mental illnesses that can be traced directly to biological causes include depression, which has been associated with dietary deficiency in niacin, that's a B3 vitamin, cognitive and behavioral impairments caused by HIV, human immunodeficiency virus, and obsessive compulsive disorder in children, which is theorized to be caused by streptococcal pharyngitis, so strep throat. Remember that some causes of mental disorders can be completely biological, while others may have psychological underpinnings. I now want to lead you into the first major mental disorder that we cover in this lecture, anxiety. When introducing anxiety, I firstly want you to understand that there is a difference between fear and anxiety. Fear is defined as an adaptive response to threatening situations. It can be learned, innate, or species-specific. Anxiety disorders primarily reflect an inappropriate expression of fear or stress to a situation. And this response is likely due to overactivity of our sympathetic nervous system, which, if you recall from our first lecture, is our fight or flight response. Anxiety is an innate and natural response in high pressure or uncertain situations. However, when prolonged, this disproportionate level of anxiety can interfere substantially with an individual's ability to cope and deal with situations. It can also result in long-term structural changes in critical underlying brain circuitry, such as dysregulation of the HPA axis, which we will cover shortly. Some common anxiety disorders that we will discuss throughout this subject include panic disorder, agoraphobia, obsessive-compulsive disorder, generalized anxiety disorder, specific phobias, social phobias, and post-traumatic stress disorder. We'll also take you through the first few during today's lecture. So the first subtype of anxiety that we will discuss is panic disorder. It's quite a common form of anxiety experienced by most people at some stage throughout a lifespan. Panic disorder affects approximately 2% of the population and are characterized by short bursts or episodes of intense fear or dread that can occur without warning. Panic disorders are brief, well-defined bouts of anxiety. The important thing to remember is that with panic disorders, there is most often a clear cause for panic attacks, and so individuals may often try to avoid situations that would lead or cause to another attack. One of the worst aspects of panic disorders is that the fear of having another panic attack can cause subsequent panic attacks. This can lead to secondary phobias and avoidance behavior, which is a major symptom of anxiety disorders. Now, panic disorders are associated with sympathetic overactivity. So thus, the main symptoms observed are predominantly physiological and include palpitations, shortness of breath, and chest pain, which may last for 30 minutes. So we see a general overactivation of the sympathetic nervous system. For anyone that has had panic attacks or has had one at some point throughout their life, you'll know that it can be quite a terrifying experience. Some people compare it to having a heart attack and actually having feelings of impending doom. While some individuals can have minor panic attacks, others can have quite debilitating cases. Interestingly, panic attacks are twice as common in women than in men. The reasons for this are unclear in the literature, but a high reporting of panic attacks in females could account for this. So unlike panic disorders, agoraphobia affects an estimated 5% of the population and is an example of a specific type of phobia. So remember, phobias are fears specific to things, objects, activities, and/or situations. It should be noted that agoraphobia refers to the avoidance of situations and places where escape is perceived as difficult. The best examples of this include being alone outside home, being in a large crowd, like at a music festival, in a car or an airplane, or even an elevator. Again, agoraphobia is also twice as common in women than in men, and similarly can lead to avoidance behavior, and this can exacerbate agoraphobia in future. I also mentioned that people who suffer from panic attacks can try to avoid situations and places that can trigger a panic attack. This also leads to avoidance behavior. If avoidance behavior becomes severe enough, the panic disorder may also be compounded by secondary agoraphobia. Another familiar disorder you have probably all encountered at some stage in your lives is obsessive compulsive disorder, which is commonly abbreviated to OCD. Now, OCD is not when a person has a preferred type of pen or color highlighter that they use, nor is it when someone likes to be neat or meticulous. It can be much more pervasive than that. Obsessive compulsive disorder affects an estimated 2 to 3% of the population over the lifetime, with both genders affected equally. It is characterized by the presence of obsessions and or compulsions. Obsessions are repetitive, persistent, and worrying thoughts, images, impulses, or urges, and can be intrusive, whereas compulsions are repetitive behaviors undertaken by an individual to achieve a sense of finality or completeness. They are almost like intense tick-the-box exercises that need to be completed. Usually, when these tick-the-box exercises are not completed, it leads to extreme distress in the individual and can even be debilitating, leading to an interference in everyday life. The most common obsessions and compulsions reported in patients with OCD involve meticulous attention to hygiene, such as frequent washing or cleaning, but there are others that also exist, such as concerns about symmetry, ordering, and counting. These repetitive behaviors are performed to reduce anxiety linked to the obsession. And while some individuals with OCD may have minor compulsions, like checking that they've turned the oven off 3 times, other individuals may have more severe forms of OCD. So now we'll start focusing on the biological basis, specifically providing information on our HPA axis. Now, although early neuroscientists suggested that mental disorders resulted from demonic possession, it is now widely accepted and understood that mental disorders do have firm biological bases. The biological basis for disorders like anxiety and depression are still not fully understood, but there are common theories that help shape our current understanding of them. Mental illnesses like anxiety and depression commonly involve the activation of the hypothalamic pituitary adrenal axis, that's the HPA axis, and this is a complex system that secretes cortisol during stressful situations. It is important that you become familiar with this system and how the hypothalamus controls this response. It will help shape your understanding of mental disorder, the stress response, and other areas of neuroscience throughout the subject. So briefly, the stress response is characterized by avoidance behavior, increased vigilance and arousal, activation of the sympathetic division of the autonomic nervous system, and the release of cortisol from the adrenal glands. Now, during a stressful situation, the onset of stress is detected by the hypothalamus, and this secretes corticotropin-releasing hormone. This then triggers the anterior pituitary gland to secrete adrenocorticotropic hormone, which travels in the bloodstream to the adrenal glands lying superior to the kidney. The adrenal glands subsequently release cortisol, which assists in regulating the stress response. Now, typical short-term responses associated with the activation of the sympathetic nervous system include increased mental alertness, increased blood pressure, increased heart rate, increased respiratory rate, reduced digestive activity and urine output, and increased utilization of glucose. When we consider the HPA axis more closely, we see that the stress response utilizes a positive and negative feedback loop that is tightly regulated by a unique push-pull mechanism of 2 key brain structures, the amygdala and the hippocampus. The amygdala, which also plays crucial roles in regulating heart rate and linking specific emotions with memories, receives sensory information from the thalamus and descending inputs of the neocortex. The basolateral nuclei then process this information and project the signal to the bed nucleus of the stria terminalis. This activates the HPA axis. On the other hand, the hippocampus, which is also a part of the limbic system and involved in memory function and storage, deactivates the HPA axis, alerting the HPA to cease secreting cortisol. Now, the hippocampus contains specialized populations of glucocorticoid receptors that are sensitive to circulating cortisol. However, excessive cortisol release triggered by prolonged stress can lead to the degeneration and damage of these sensitive neurons in the hippocampus. The loss of these receptors means the hippocampus cannot signal deactivation of the HPA axis, leading to a more pronounced stress response and hypersecretion of cortisol. This eventually leads to dysregulation of the HPA axis, which is a cardinal feature of anxiety and affective mood disorders such as depression. Thankfully, we have various treatment options available for controlling and treating anxiety disorders, and these can be broadly divided into non-medical, so psychotherapy, or medical, anxiolytic medications. Psychotherapy primarily aims to reinforce that the stimulus or stimuli perceived to be dangerous or threatening is not. Multiple sessions are usually required and involve the progressive and increasing exposure to the stimulus or stimuli that is responsible for triggering or causing the anxiety. If psychotherapy fails to treat the anxiety, anxiolytic medications, which essentially translates to anxiety reducing, may be used. Many neurotransmitter systems are implicated in the neural mechanisms of anxiety. However, the main systems include gamma-aminobutyric acid, so GABA, norepinephrine, and serotonin. Specifically, GABA is a major inhibitory neurotransmitter located in the cerebral cortex, cerebellum, and various interneurons throughout the brain and spinal cord. It exerts direct inhibitory effects throughout the central nervous system by opening chloride channels. For example, drugs that act upon GABA receptors, such as benzodiazepines, enhance GABA activity throughout the brain, resulting in sedation and relaxation. But because tolerance and physical dependence develop rapidly, benzodiazepines are usually prescribed for the short-term acute episodes of anxiety. We also have selective serotonin reuptake inhibitors, more commonly known as SSRIs. One well-known SSRI is Prozac, known by its chemical name fluoxetine. These drugs selectively block the reuptake of serotonin in that narrow space that separates two neurons, the synaptic cleft, prolonging the activity of serotonin. Serotonin is also known as 5-hydroxytryptamine, or 5-HT, and has been shown to play important roles in emotional states, mood, and even body temperature. Thus, these characteristics identify serotonin as a viable therapeutic for the treatment of anxiety disorders. However, as serotonin together with noradrenaline and dopamine comprise the reticular activating system, which awakens the forebrain, insomnia is usually an adverse effect commonly reported in patients using SSRIs. But interestingly, SSRIs have an adaptive advantage. At the 4 to 6 week period, they stimulate the formation of new connections, notably in the hippocampus. This adaptive advantage explains why after 4 to 6 weeks of treatment, most patients taking SSRIs notice improvements in their mood and memory. Although SSRIs are the most commonly prescribed medications, there are newer medications beginning to target corticotropin-releasing hormone receptors. Keep in mind, for some individuals, psychotherapy and anxiolytic medication can be used in conjunction for the treatment of anxiety disorders, but treatment options will often depend on several factors, including the individual, the type of anxiety, and the severity of the anxiety disorder. So we will now move on to mood disorders, which explores mental disorders such as depression and bipolar disorder. Mood disorders are also known as affective disorders. They are long-term changes in emotional states, which complicates mood regulation. Similar to anxiety, they are also often invisible, making it challenging to identify those suffering from a mood disorder. The main affective disorders you will need to be familiar with include all forms of depression, including major depression and dyspnea. You'll also need to be conversant with bipolar disorder, including its associated components such as mania and hypomania. Major depression is a debilitating disease and is the most common mood disorder, affecting about 5 to 6% of the adult population worldwide each year. Although feelings of sadness may come and go throughout a person's lifetime, when this feeling becomes prolonged and excessive, it can interfere with an individual's ability to function in daily life, and this is then considered to be classified as a depressive disorder. For a formal diagnosis, feeling of depression needs to be present for more days than not over several weeks. The main symptoms of major depression include a loss or an increased appetite, insomnia or hypersomnia, fatigue, feelings of worthlessness or guilt, apathy, social isolation, diminished concentration, and low self-esteem and estimation of one's worth. These symptoms last for at least 2 weeks and also involve noticeable changes in mood. Interestingly, major depression occurs roughly twice as common in women than in men. It has also been linked to an increased risk of developing chronic diseases such as diabetes mellitus, as well as adverse cardiovascular outcomes. We assume that depression may be actually equally as present in men and women. However, men may be less likely to seek help for depression, which leads to depression in men being underreported. Men may also not recognize that they are suffering from depression, as it may manifest differently in men when compared to women. While women more often suffer from feelings of sadness, men may show signs of anger and irritability. Another expression of depression is dysthymia. This is a milder version of depression and accounts for about 2% of depressive symptoms seen in members of the general population. When we fluctuate between periods of depression, being extreme lows, and mania, being extreme highs, this is known as bipolar mood disorder. Bipolar mood disorder is a recurrent mood disorder where an individual fluctuates between two extremes of a mood spectrum. As mentioned, a person will fluctuate between periods of depression, so extreme lows, and periods of mania, extreme highs. Manic symptoms include an inflated self-esteem, decreased need for sleep, increased talkativeness, also known as garrulousness, racing thoughts, distractibility, increased goal-directed activity, and spending sprees. Mania can often lead to risky behavior too. The other thing to note is that when a person fluctuates between these two states, it is not a short-term change. A person may feel depressive for a couple of weeks, then manic for a month, followed by depressive for another 4 months, then hypomanic for a few days. So what we tend to see is more long-term fluctuations in mood rather than short-term fluctuations. There are two types of bipolar disorder. Type 1 bipolar disorder involves manic episodes with or without depression, whereas type 2 bipolar disorder involves hypomania, which is a milder form of mania. Type 2 bipolar can lead to increased efficiency. Accomplishment and creativity is commonly associated with major depression, and as previously mentioned, fluctuations can last days, weeks, and even months. If hypomania alternates with periods of mild depression, it is known as cyclothymia. So as we mentioned when we discussed the biological basis for anxiety, the biological basis for depression is yet to be fully understood, but there are theories that help shape our understanding. The first biological theory for depression is the monoamine hypothesis. This theory suggests that depression involves the depletion of monoamines, such as serotonin and norepinephrine. These neurotransmitters comprise a reticular activating system, which awakens the forebrain. So, it's based on problems with various diffuse modulatory systems. We have seen this through various drug therapies which have resulted in depression too. For example, Reciprine, which is a drug used to control high blood pressure, has been seen to cause depression and is associated with the depletion of catecholamines and serotonin. Imipramine, an antidepressant, also acts to inhibit the reuptake of serotonin and norepinephrine, which has been seen to cause a subsequent elevation in mood. So in turn, this resulted in the development of the monoamine hypothesis of mood disorders, which states that mood is tied to levels of released monoamine neurotransmitters, notably norepinephrine and serotonin, and therefore depression is due to deficit in one of these diffuse modulatory systems. Although the monoamine hypothesis is popular, there is increasing evidence to support another theory known as the diathesis stress hypothesis. It may be possible that both the monoamine hypothesis and diathesis stress hypothesis work hand in hand when considering the biological basis for depression. So the diathesis stress hypothesis states that the greater a person's individual vulnerability for developing depression, the less environmental stress it would take for them to actually become depressed. Therefore, childhood stressors and genetic factors may decrease an individual's resilience or threshold for developing a disease or disorder. If that individual has large amounts of stress later in life, they may be more vulnerable to developing a disorder, such as depression. The diathesis stress hypothesis also involves the HPA axis in its basis, where the HPA axis is the main site where genetic and environmental influences converge to cause mood disorders. So to reiterate, a diathesis is essentially a predisposition or vulnerability for something. This diathesis can be biological, genetic, cognitive, or situational. Thus, the diathesis stress model serves to explore how this vulnerability, diathesis, interacts with environmental influences, stressors, to produce disorders like depression. The diathesis stress model asserts that if the combination of the predisposition and the stress exceeds a threshold, the person will develop a disorder. Thus, the greater a person's individual vulnerability for developing depression, the less environmental stress it takes for them to actually become depressed. So moving on to treatment options for affective disorders, we can use a mix of psychotherapy, cognitive behavioral therapy, antidepressant medication, and in some instances, electroconvulsive therapy. ECT, or electroconvulsive therapy, involves the use of localized electrical stimulation, where an electrical current is passed between two scalp electrodes. Obviously, in these cases, the patient is given anesthesia during treatment. The advantage of electroconvulsive therapy is that it provides quick relief. However, there are disadvantages and adverse effects of ECT, such as memory loss, and this can occur for up to 6 months. It can also impair the storage of new information. We can also use psychotherapy as an avenue for treating affective disorders. Psychotherapy usually involves helping a patient overcome negative thoughts and behaviors, and is a common treatment option for mild to moderate depression. So we have various antidepressant medications that we can use, and we would like to take you through the drug treatments in a little bit more detail. Generally, all drug treatments for depression will aim to increase the amount of monoamine neurotransmitter levels. Each class of medication that we're about to discuss are quite effective, so when prescribing antidepressant medication, we tend to consider the side effect profile for each class. As we look at the different classes, there are three main groups: monoamine oxidase inhibitors and tricyclic antidepressants, which are our first generation antidepressants, and SSRIs, which are our second generation antidepressants. Our first generation antidepressants are the oldest types, while the second generation antidepressants are the newer drug types. First generation antidepressants generally have the largest side effect profile because they are less specific and selective, which we'll explain in a minute. So to start, I'll take you through monoamine oxidase inhibitors, also known as MAOIs, and these are an example of a first-generation antidepressant medication. Monoamine oxidase inhibitors work on all monoamines and inhibit monoamine oxidase, which is an enzyme that breaks down monoamine neurotransmitters in the synaptic cleft. Because it stops this enzyme from working, it results in more monoamines being left in the synaptic cleft. So this essentially means that you have more dopamine, more serotonin, and more epinephrine available for use. We then have tricyclic antidepressants, also known as TCAs. Tricyclic antidepressants are also an example of a first-generation antidepressant medication. And specifically, they work on serotonin and norepinephrine. They work by interfering with the reuptake of serotonin and norepinephrine, meaning that they are available in the synaptic cleft for longer periods of time to work their magic. And finally, we have selective serotonin reuptake inhibitors, also known as SSRIs. SSRIs, as mentioned, are a second-generation antidepressant that specifically work on serotonin. They act by blocking the reuptake of serotonin, allowing it to remain in the synaptic cleft for longer periods of time. Because selective serotonin reuptake inhibitors are much more specific and selective, they have a smaller side effect profile compared to the other classes of medications mentioned. I'd also like to mention some newer types of medications, such as selective noradrenaline reuptake inhibitors, noradrenaline and dopamine reuptake inhibitors, and noradrenaline and dopamine releasing agents, which all provide more specific and selective options for increasing the amount of monoamine neurotransmitter available. We also have cognitive behavioral therapy for the treatment of affective disorders. Cognitive behavioral therapy suggests that both functional and non-functional behavior can be learned due to neuroplasticity that continues across the entire lifespan, and that cognitive activity contributes to dysfunctional behavior and emotional experience through focusing on negative aspects of things. In turn, it suggests that cognitive activity may be changed by assisting patients in identifying and challenging unhelpful thoughts and learning practical self-help strategies. Now, cognitive behavioral therapy can be used for all types of depression and anxiety, for example, arachnophobia, obsessive-compulsive disorder, panic disorder, social phobia, major depressive disorder, and chronic fatigue syndrome, and has a strong track record of being helpful with such disorders. Finally, we have new treatment options. Treatment with antidepressants dampens the hyperactivity of the HPA system. This may be due to increased glucocorticoid receptor expression in the hippocampus, and this occurs in response to long-term elevation of serotonin levels. Prolonged treatment with SSRIs has also been shown to increase neurogenesis, which means that there is new neuron proliferation in the brain, especially in the hippocampus. Finally, we also have deep brain stimulation, and this can be utilized when severe depression fails to respond to other treatment. In this method, electrodes are implanted deep within the brain. Electrical stimulation is then used to decrease activity in brain circuits that are chronically overactive, and this provides immediate relief from depression. So this concludes the first part of the lecture on mental illness. We are now going to move into the schizophrenia section of this lecture. So following the second part of this lecture, which focuses on schizophrenia, you should be able to explain the classification systems of schizophrenia, explain and discuss the symptoms associated with schizophrenia, discuss the biological basis of schizophrenia, including the involvement of genetics, the environment, the dopamine hypothesis, and the glutamate hypothesis, and finally discuss and explain the utilization of conventional and atypical neuroleptics in the treatment of schizophrenia, in addition to their differences. So schizophrenia is a severe neuropsychiatric disorder that affects approximately 1% of the population worldwide. It is characterized by psychological disturbances, including delusions, hallucinations, which are mainly auditory, and bizarre and irrational behavior and thoughts. Schizophrenia can also be classified as a syndrome because it has lots of different symptoms, and different patients will have different mixes of these symptoms. Although schizophrenia quite literally means split mind, we want you to remember that it is not a split personality or multiple personalities. Rather, it is a loss of contact with reality. To date, we still do not know what causes schizophrenia. The scientific literature indicates the etiology is complex, resulting from interactions between both genetic and environmental risk factors. The main risk factors that have been implicated with developing schizophrenia include advanced age at time of conception, malnourishment during pregnancy, frequent cannabis use during adolescence, prenatal exposure to infection, and social disadvantage. It is these risk factors that are hypothesized to influence neurodevelopment. Now, while schizophrenia may be triggered by a stressful event, it usually occurs during early adulthood and persists for life, generally mid-20s for men and late 20s for women. It is also classified based on symptoms, which can be categorized as either positive or negative. This will be explained shortly. There are 4 subtypes of schizophrenia. The first is paranoid schizophrenia, and this involves delusions of persecution and delusions of grandeur. We then have catatonic schizophrenia, and this involves motor disturbances, ranging from muscular rigidity to random motor activity, for example, staring or fidgeting. We then have disorganized schizophrenia, and this type involves a severe deterioration of adaptive behavior, emotional indifference, incoherence, and social withdrawal. And finally, we have undifferentiated schizophrenia. This is when a patient demonstrates a mixture of symptoms that overlap between the different subtypes described above. However, a newer model is now used for classifying schizophrenia, and these are classified as either positive or negative subtypes. So as mentioned on the previous slide, the newer revised model groups patients into type 1 schizophrenia, also known as the positive symptoms, or type 2 schizophrenia, which is also known as the negative symptoms. Type 1 schizophrenia encompasses positive symptoms. It is important to note that when we say positive symptoms, we do not imply good symptoms. Rather, these are just symptoms that add to normal behavior, so a behavioral excess. Positive symptoms of schizophrenia include delusions. These are fixed false beliefs held firmly in the face of contradictory evidence. Hallucinations, which involve distorted sensory perceptions and the inability to determine what is real and what is not. Disorganized speech, where an individual cannot articulate coherent sentences. And finally, disorganized behavior, for example, behaving in an odd manner and struggling to maintain attention. Type 2 schizophrenia involves negative symptoms. These are symptoms that subtract from normal functioning, a behavioral deficit, or reflect an absence of behavior. The negative symptoms include reduced or blunted emotion, reduced speech, known clinically as alogia, inability to experience pleasure, also known as anhedonia, a lack of motivation or avolition, for example, the inability to initiate or persist with goal-directed activities, social withdrawal, and memory impairment. It is important to note that patients with schizophrenia tend to fluctuate through phases. First, they experience the prodromal phase, where they appear withdrawn. This is then followed by the active phase, which is characterized by severe symptoms, and finally a residual phase, which will more often result in disturbances in cognition. No objective measurement exists to diagnose schizophrenia. The process for diagnosing schizophrenia is based on rudimentary and subjective observations and involves carefully evaluating symptoms and ruling out others. To be diagnosed with schizophrenia, an individual must demonstrate at least 2 of the following characteristic symptoms during a 1-month period: delusions, hallucinations, incoherent speech, odd or irrational behavior, and negative symptoms, so reduced speech, blunted emotion, reduced motivation, and others previously mentioned. Schizophrenia has been determined to have a biological basis. We will discuss these initially here, then we will explore them in more detail in later slides. Firstly, there is the interaction between genes and the environment. Schizophrenia has shown a genetic component where the more genes you share with a family member who has schizophrenia, the more likely you are to develop the disorder. We see this through various twin studies, which you will learn more about in your practical components. Just bear in mind that no single gene per se causes schizophrenia, but many genes have been implicated and contribute small increments to the risk of schizophrenia. We also have the dopamine hypothesis, and this is the prevailing hypothesis suggesting that psychotic episodes in schizophrenia are triggered by the activation of dopamine receptors. Finally, we have the glutamate hypothesis, and glutamate is an excitatory neurotransmitter. This was determined from phencyclidine, PCB, a mind-altering drug also known as angel dust, which was seen to cause hallucinations and paranoia. PCP acts on NMDA receptors, a subtype of glutamate receptor. Therefore, this raises the possibility that glutamate plays a role in schizophrenia. So going back to the genes and environment theory for schizophrenia, it has been determined that schizophrenia has a significant heritable component. Genetic studies indicate that the likelihood of developing the disorder is related to the number of genes shared with an affected family member. So as mentioned, the more genes that you share with a family member who has schizophrenia, the more likely you are to develop the disorder. However, schizophrenia is not entirely a genetic disorder. If this were true, every person who shares genes with an affected family member would develop the condition. Therefore, environmental factors are also implicated and must contribute. The main environmental risk factors that have been associated with an increased risk of developing schizophrenia include viral infections during fetal and infant development, advanced age at time of conception, malnourishment during pregnancy, frequent cannabis use during adolescence, social disadvantage, and even stress, both acute and chronic, throughout life. So here's a question for you to consider. Jensen's mother was severely malnourished during her pregnancy with him. According to recent research, Jensen would have an increased vulnerability for the development of schizophrenia. So the answer should be C, in that Jensen has an increased vulnerability for developing schizophrenia because, as mentioned earlier, poor maternal nutrition is a risk factor for developing schizophrenia. Now, schizophrenia is also associated with underlying changes in the brain, which can be observed in neuroimaging techniques such as MRI. The first change mentioned on the slide is that we see a reduction in frontal lobe size and neuron density, in addition to thinning of cortical regions of the brain. We also see a marked change in the orientation of neurons. In a healthy human brain, the orientation of neurons in the hippocampus are generally organized. This consistent organization allows for better and reliable communication between neurons. In individuals with schizophrenia, the neurons in the hippocampus are highly disorganized or haphazard. That is, they lack any obvious organization or arrangement. This disorganized orientation of neurons is theorized to underlie the irrational and disorganized speech and behavior commonly reported in patients with schizophrenia. As can be seen in the MRI scan, we also see an enlargement of the lateral ventricles. However, this enlargement is not associated with the usual symptoms of increased pressure, which typically causes ventricular enlargement. Researchers suggest this results from the shrinkage of brain tissue. Hence, this makes the ventricles appear larger. The loss of brain tissue may also explain why individuals with schizophrenia have lighter brains too. And interestingly, imaging studies also reveal reductions in the size of the temporal lobe structures, for example, the amygdala, the hippocampus, and the entorhinal cortex. So next up, I'll take you back to the dopamine hypothesis. Now, there are a couple of reasons that we associate dopamine with schizophrenia. The first is because amphetamines cause dopamine release. An amphetamine overdose has been seen to cause psychotic episodes, similar to that seen in patients with schizophrenia. Psychotic episodes in schizophrenia are also triggered by the activation of dopamine receptors. If amphetamines cause schizophrenia-like symptoms by increasing dopamine activity, perhaps schizophrenia is related to excessive dopaminergic transmission. We also know that the central nervous system effects of drugs that lessen schizophrenia symptoms are blockers of dopamine receptors, notably D2 receptors. And so we see a correlation between the dosage of neuroleptics effective for controlling schizophrenia and their ability to bind to D2 receptors. Again, supporting the idea that dopamine is involved in schizophrenia is the fact that a number of medications that affect dopamine transmission often improve symptoms of schizophrenia. Generally, in schizophrenia, we show there are too many receptor sites on nerves receiving chemical messages. Hence, there are large amounts of neurotransmitters produced. As the number of receptor sites increase, so too do the number of messages sent. This results in too many messages being sent throughout the brain, and it is this that researchers believe causes the bizarre and peculiar symptoms seen in patients with schizophrenia. Next up, we have the glutamate hypothesis. And according to the glutamate hypothesis, the disorder reflects diminished activation of NMDA receptors in the brain. Recall earlier that NMDA receptors are a subtype of glutamate, which is an excitatory neurotransmitter. We have seen that the drug phencyclidine, PCP, can induce symptoms that mimic schizophrenia, so it has been associated with both positive and negative symptoms. Low doses of PCP administered to rats produce changes in brain biochemistry and behavior that resembles patients with schizophrenia. And mice that have been genetically engineered to express fewer NMDA receptors also display similar behavior to that observed in patients with schizophrenia. So finally, we are going to take you through the treatment options for schizophrenia, which often involves a mix between drug therapy and psychosocial support. Drug therapy involves neuroleptic medication and generally aims to decrease psychotic symptoms, thoughts, and behaviors. Firstly, we have conventional neuroleptics, for example, chlorpromazine and haloperidol, and these are also known as typical neuroleptics. These are first-generation drugs that act specifically on D2 receptors. The conventional neuroleptics specifically act to reduce the positive symptoms of schizophrenia. However, the side effects typically involve symptoms that resemble Parkinson's disease and include rigidity, tremor, and difficulty initiating movements, and this is because they block receptors in the striatum. Chronic doses can also result in tardive dyskinesia, which involves involuntary lip and jaw movements. We then have our atypical neuroleptics, such as clozapine and risperidone, and these are second-generation drugs. The atypical neuroleptics generally avoid most side effects because they do not act directly on the dopamine receptors in the striatum. They are also more effective at treating the negative symptoms of schizophrenia. There is now more emerging research coming up that shows increasing NMDA receptor response together with decreasing D2 receptor activation may further reduce the symptoms of schizophrenia, and hence this is an area of research that is being actively investigated. Last but not least, we also have transmagnetic stimulation as a treatment option for treating schizophrenia. Transmagnetic stimulation involves placing a magnetic field over the scalp and can be applied to localized brain regions. In schizophrenia, transmagnetic stimulation usually targets the frontal lobes for auditory hallucinations and the auditory cortex. The high-frequency transmagnetic stimulation to the prefrontal cortex has been promising for treating the negative symptoms. However, one drawback is that daily transmagnetic stimulation lasts for about 20 minutes to produce any significant reductions in the symptoms. And unless it is done regularly over a prolonged time periods, long-term follow-ups have been shown to have a return of the hallucinations over time. So transmagnetic stimulation may be better used in conjunction with medication, or at least long-term if it is being used on its own. So this concludes the mental illness and schizophrenia lecture. We again would like to thank you for tuning in. Should you have any questions, please contact Shamona Maharaj, who developed the lecture content, at shamona.maharaj@uts.edu.au. Thank you.